Hi friends, I'm Dr. Jeev Ram. Today I will discuss about epilepsy and its management. A seizure is a paroxysmal event characterized by abnormal, excessive, hypersynchronous discharge of cortical neuron activity. Epilepsy can be defined as a chronic seizure disorder or a group of disorders characterized by seizures that usually reoccur unpredictably in the absence of a consistent provoking factor. Epilepsy is not contagious, it is not a mental illness or a cognitive disability. The neurological dysfunction seen in epilepsy can begin at birth, childhood, adolescence, or even in adulthood. Classification: partial seizures are simple seizures without impairment of consciousness, with motor symptoms, with spatial sensory or somatosensory symptoms, with psychic symptoms. Complex seizures with impairment of consciousness, simple partial onset followed by impairment of consciousness, impaired consciousness at onset, secondary generalized, partial onset evolving to generalized tonic-clonic seizures. Generalized seizures: absence, myoclonic, clonic, tonic, tonic-clonic, atonic, infantile spasms. Unclassified seizures: status epilepticus. Partial seizures: common 80% patients. Simple partial seizures do not cause loss of consciousness. Signs and symptoms: motor, convulsive jerking, chewing, motions, lip smacking. Sensory and somatosensory: paresthesias, auras, automatic, sweating, flushing, pupil dilation. Behavioral: hallucinations, dysphagia, impaired consciousness, rare. Complex partial seizures: impairment of consciousness, purposeless behavior is common. Affected person may wander about aimlessly. Aggressive behavior, violence, automatism, picking at clothes, visual, auditory, or olfactory hallucinations. Generalized seizures affecting both hemispheres, diffuse, 3 types: idiopathic epilepsies, age-related, genetic origin, symptomatic epilepsies, a consequence of a known suspected underlying disorder of CNS, cryptogenic epilepsies, disorder of a hidden cause, age-related. Absence seizures: petit mal, alterations of consciousness, absence lasting 10 to 30 seconds, starting with ocular eye blinking and loss in postural tone, 100 or more daily. Onset occurs from 3 to 16 years, disappear by 40 years. Myoclonic: sudden involuntary jerking of facial, limb, or trunk muscles in rhythmic manner. Clonic: sustained muscle contractions alternating with relaxations. Tonic: sustained muscle stiffening. Tonic-clonic grand mal epilepsy: sudden loss of consciousness. Tonic phase: patient become rigid and falls to the ground. Respiration is interrupted. Back arches last about 1 minute. Clonic phase: rapid muscle jerking, muscle flaccidity, incontinence, tongue biting, tachycardia, heavy salivation. During post-ictal phase: headache, confusion, nausea, drowsiness, disorientation, may last for hours. Atonic: drop attacks, sudden loss of postural tone, patient falls to the ground, occur primarily in children. Unclassified seizures: neonatal, status epilepticus, seizure occur repeatedly with no recovery of consciousness between attacks. Causes: high fever, especially in infants, drug use, alcohol withdrawal, near drowning or lack of oxygen from another cause, metabolic disturbances, head trauma, brain tumor, infection, stroke, complication of diabetes or pregnancy. Causes of epilepsy: stroke, brain tumor, brain infection, past head injury, drug use, alcohol withdrawal, metabolic problems, other neurological conditions, high fever, especially in infants, genetic factors. Epilepsy may occur with developmental disabilities, autism, cognitive impairments. But the majority of people who have epilepsy do not have other impairments and live very normal lives. Pathophysiology of epilepsy. Paroxysmal discharges in cortical neurons. A seizure originates from gray matter of any cortical or subcortical area that causes abnormal firing of neurons and breakdown of normal membrane conductance and inhibitory synaptic currents that causes locally focal seizure and widely generalized seizure. Abnormality of potassium conductance, defect in voltage sensitive ion channels, deficiency in membrane ATPase, neuron membrane instability causes seizures, deficiency of inhibitory neurotransmitters, increase in excitatory neurotransmitters promotes abnormal neuronal activity that causes seizure. Diagnosis of epilepsy, electroencephalogram EEG, neurological imaging studies, magnetic resonance imaging MRI, functional MRI, computed tomography CT scan, positron emission tomography PET, single photon emission computerized tomography SPECT. You can see the chart showing the complete management of all types of epilepsy, and the chart is also showing seizure type with drug of first choice, second choice, third choice, and fourth choice. General measures for epilepsy. Immediate emergency measures if patient is seen convulsing. Ensure that patient does not harm himself. Moving person away from sharp objects. Clothing about the neck should be loosened. Ensure the airway is clear. Remove any secretions or vomitus from the mouth or nose. Do not force a spoon or tongue depressor into the mouth. Remove false teeth if present. After convulsions, cease. Turn the patient into semi-prone position by turning the patient on the side with one leg bent and the other leg straight. Monitor fits. Fits chart. Pharmacological treatment of epilepsy. Anticonvulsant drug therapy. Traditionally, a single seizure has been regarded as an indication for investigation and assessment, but not for drug treatment unless a second attack follows closely or based on the circumstances of the seizure. Drug treatment should certainly be considered after two seizures, and the type of drug depends on the type of seizure. The underlying abnormality must also be corrected if possible. Guidelines for use of anti-epileptic drugs begin with a single drug at the lowest dosage range. If seizures not controlled, increase dose to upper limit of dosage range or until side effects appear. If seizures are poorly controlled, change to a different drug by gradually reducing dose of initial agent while simultaneously introducing the new one. This usually takes 3 to 4 weeks. Try 3 single drugs before resorting to drug combinations, which help in only a minority of cases. Treatment can be stopped only after 2 years seizure-free and after a full evaluation and discussion with patient. Grand mal epilepsy. Gradually increasing doses of a single drug should be tried first. Tablet sodium valproate 250 to 500 mg, 1 tablet twice daily. Gradually increase to a maximum of 60 mg per kg per day in 3 divided doses. If not controlled, tablet levetiracetam 25 mg, 1 tablet daily to 100 mg, 5 tablets daily in 2 to 3 divided doses. If not controlled, then tablet sodium valproate 500 mg, 60 mg per kg per day in 3 divided doses, plus tablet lamotrigine 25 mg, half tablet once daily to 100 mg, 5 tablets in 2 divided doses, or tablet sodium valproate 500 mg, 60 mg per kg per day in 3 divided doses, plus tablet topiramate 50 mg one tablet daily for 1 week, then one tablet twice daily, maximum 16 tablets in 2 doses. Partial seizures. Gradually increasing doses of a single drug should be tried first.